Hello, my name is Richard Stone, and I'm at the Dana-Farber Cancer Institute in Boston. I'll be talking about acute myeloid leukemia in older adults. Here are my disclosures over the past 3 years. AML is a deadly disease caused by an unbridled proliferation of hematopoietic stem cells. Risk factors rarely include germline mutations or hereditary issues. The median age is 68 to 70, and prior chemotherapy for other cancers, ionizing radiation, or industrial solvents can be risk factors. When someone's diagnosed with AML, we'd like to know things about the patient, namely the age, whether the patient's had prior therapy for other cancers, or a prior bone marrow stem cell disorder. Regarding the disease, we need to know the cytogenetics, gross chromosomal DNA changes, and the mutations, particularly the ones listed here, that can either portend a favorable or unfavorable prognosis. The prognosis in general for AML patients of this age group is poor. It's improved a bit over the 6 preceding decades, but that may be more because of supportive care than anti-AML therapies, although you'll hear about some hopeful new drugs in a minute. Why do older adults do worse with our current therapy? Number one, the older patients have a decreased ability to clear chemotherapy. They have more comorbid diseases. They have an impaired hematopoietic stem cell reserve that generally results in longer cytopenias when they get chemotherapy. And of course, the disease is different. There's a higher ratio of unfavorable to favorable cytogenetics in older adults, and there's a higher expression of drug resistance proteins. Moreover, there's also a higher likelihood of genes which are associated with myelodysplasia in older adults that have apparently clinically de novo AML, as shown in this slide here. P53 mutations and secondary type AML mutations in older adults pretend for poor prognosis, yet those who don't have those may be able to do fairly well with standard chemotherapy. The heterogeneity, which has to do, as I mentioned, with host factors and disease factors, can be leveraged for better choice of therapy. One important issue that you'll hear about during this meeting is geriatric assessment, as promulgated by Heidi Kleppen and colleagues through the Alliance Cooperative Group. Excitingly, there have been 3 recently approved drugs for older adults alone out of the 10 or so new drugs that have been approved for AML in general over the past few years. And I'll go over the trials that led to the approval of these drugs at this time. The first drug is approved for upfront use, and basically that's a new formulation of the old drugs, daunorubicin and cytarabine, that we typically use to treat AML patients of all ages. And this one is a liposomal encapsulated version of the 2 drugs, cytarabine and daunorubicin, that releases those 2 drugs at a 5-to-1 molar ratio, which seems to be optimal for killing the leukemic cell. And this drug hangs around in the bone marrow, which may be the reason why, number one, it kills leukemic cells fairly well, and also why it's associated with somewhat prolonged cytopenias. But the trial proving that this was a useful agent was a drug company-sponsored trial that enrolled patients with previously untreated AML between age 60 and 75. They had to be able to tolerate intensive chemotherapy in the opinion of the investigator, and they had to have some version of secondary AML, either therapy-related AML, AML with prior MDS or CMML, or de novo AML with MDS-type karyotype. And again, it was a randomization in a 2-to-1 fashion from induction chemotherapy to 1-to-1 fashion of induction chemotherapy and the CPX-351 with survival being the primary endpoint. And indeed, survival was prolonged in those randomized to CPX-351 with a significant hazard ratio, 31% lower chance of dying with CPX-351, higher remission rate, and there was no increased cost in terms of upfront mortality. Moreover, if you had a transplant at some point during your disease course, but were exposed to CPX-351 before the transplant, you tended to do much better than if you were exposed to 3+7 before the transplant, possibly due to the fact that CPX-351, although this was not measured, led to remissions at a lower level of disease burden when the remission was achieved. The second drug I want to talk about is Venetoclax, which is really a game changer in AML right now. That's a drug that binds to BCL2 and thereby prevents BCL2 from preventing programmed cell death by binding to BIM and BAX hole makers in the mitochondrial cell membrane. And so prior work showed that Venetoclax plus azacitidine or similar drugs led to a fairly high remission rate. And so this was a randomized trial of Venetoclax azacitidine, the experimental arm, versus Venetoclax plus placebo, the control arm. You could go on if you were greater than age 75 or if you were between 18 and 74 and had significant comorbidities such as heart disease or lung disease of a severe nature. The primary endpoint was overall survival. The response rate in those who were randomized to Aza-Ven was significantly higher than the response rate in those who were randomized to azacitidine and placebo, both in terms of complete remissions and overall response. And again, the trial met its primary endpoint in terms of reducing the risk of death by 34% and changing the median survival from 10 months in the control arm to 15 months in the experimental arm. So a major sea change in older adults with AML. And Aza-Ven has now become the standard of care for those who are over age 75 and some younger patients as well. Of course, the forest plot shows that not everybody benefited equally from the Aza-Ven. If you had an IDH1 or IDH2 mutation, you benefited spectacularly. Whereas if you were younger than 75 but got on the trial because of comorbid diseases, you didn't benefit as much, perhaps because this drug cannot undo the negative prognostic value of having significant heart or lung disease. And finally, oral azacitidine, or CC486, is an interesting molecule which works by causing DNA hypomethylation and thereby transcription of genes which are normally silenced. Also causes DNA damage and RNA disruption, leading to apoptosis. And the question here was, could maintenance therapy with this low-dose oral agent improve the outcome for older adults with AML who were subjected to intensive chemotherapy with consolidation mainly? So you had to be greater than age 55 to go in this trial. And you were randomized to 14 days of oral Aza monthly or placebo for 14 days monthly. And again, the overall survival was significantly prolonged, as was the relapse-free survival. So for the subgroup of patients who aren't getting allo transplants but are being treated with intensive chemotherapy over age 55, this is a new option for them. So happily, we have changed the algorithmic paradigm, if you will, for older adults with AML. For the unfit patients or those age greater than 75, azacitidine plus Venetoclax is really the new standard right now. For fit patients, we can also think of CPX351 if they have some form of secondary leukemia. And we have a new option for those who are getting intensive chemotherapy but have completed their induction and consolidation therapy, namely the oral azacitidine. We're hoping to leverage these new drugs in the form of the MyeloMatch initiative sponsored by CTEP and the NCI. It involves 3 working groups: younger AML, older AML, and MDS. 1 master screening protocol, which will assign patients based on age, fitness, AML subtype using rapid cytogenetic and molecular screening. We'll be using MRD-driven endpoints in both fit and unfit older adults. So I hope I've shown you that through good clinical trials with interesting drugs, we can improve the outcome for what historically has been a very difficult disease subset, namely older adults with AML. Thank you very much for your attention.